Buongiorno. Thank you for being here. Thank you for the invitation. Menaçante, I understood that as threatening. Is that correct?
Yes, yes, it is.
Okay, because refractory is something, threatening is something different. And of course, I have been asked to start with this stupid disclosure. I do that. I have no conflict of interest. Back to business. I would like to discuss with you a situation that I wish you will never see. So let me start with a short story. When I was a resident, many years ago, I was on duty. I think it was one of my first duty, 2 o'clock, and I have been called in the neurosurgical ward. And the alarm was a mother screaming in the ward because she saw his son, 20 years old, that all in a sudden became comatose. When I arrived, the patient was like that, and he had something like, I didn't understand that at that time, it was in pulmonary edema, neurogenic pulmonary edema. My remembering is that we pushed the patient to the angiography suite. There was no CT at the time, so it's really an old story. We did this angiography, and there was a epidural hematoma in one side. He got surgery, and he died. So that is the story I would like to start with, wishing that you will never repeat it, but I really drew a lesson from this experience. Because what happened was simply that the patient has been overseen. It was under-evaluated. He was lucid when he arrived. He was put in the ward. Apparently, he was sleeping. In fact, he became comatose. So let me start with this story to say that intracranial hypertension kills. It's a bad thing. And you see here two ways of thinking of ICP, intracranial pressure. You see, you can think of it as a peak. It goes up, and when it exceeds 20 or 30 or 40, that's really threatening. And also, it can last for some time. So the concept of the paper here is Journal of Neurosurgery 2008, is that there is a burden of intracranial pressure, meaning that you accumulate in your brain a damage which is proportional not just to the peaks, but also to the duration of intracranial pressure rise. And if you look at this very simplistic graph, you have the message. More dose, so more burden, longer ICP, higher ICP, worse outcome. The proportion between the bad and the favorable outcome splits and goes down, and the patient do badly. This is a very old concept. So let's go back to the first big data bank. Here you could have something like 1,000 cases, and more than 700 have been followed up at 6 months. And this graph, I think, says an important concept. The concept is, this is the probability of really dying or remaining in a miserable state. It was persistent vegetative state. This is 100% probability. This is 0 probability. On this axis, you have the percent of time ICP was greater than 20. So let's say a good patient who very rarely had intracranial hypertension got this probability of unfavorable outcome. On the contrary, if the ICP was higher than 20 for a greater percent of time when the measurement was performed, you see climbing, going up to 90%. On the other axis, you have mean arterial pressure. And the meaning of this plot is that the longer you have arterial hypotension, the worse is your outcome. And the combination that you have here, intracranial pressure high, arterial pressure low, is lethal, because you see, you go up to 100%. What is mean arterial pressure minus intracranial pressure? Is cerebral perfusion pressure. So the message in this plot is that perfusion of the brain matters. And low CPP, low cerebral perfusion pressure, kills. So the first concept that we should be aware of is that intracranial pressure matters because perfusion in the brain depends on ICP. But the second concept is what I have told you, telling the story of the young in the world, is herniation. And there are several kinds of herniation. If you want to have more data, please go to the New England. It was May 2 years ago. There is a review on this issue. And what you may see here is that when there is an expanding mass in one side of the brain, the tissue herniates, is dislocated, is moving, either from this side to the other side, so this is midline shift, or downward, which is uncal herniation. The uncus is the lower part of the temporal lobe. And here you have the tentorial opening, so the foramen, and the temporal lobe goes through it and causes this uncal herniation. This is uncal herniation at autopsy. The patient died, and you see here, this was part of the temporal lobe that was through the foramen of the tentorial hiatus and compressed the brain stem that you see here. This is a patient I saw 2 weeks ago. It's a horrible case. I am specialized in horrible case, but the horrible case was not because the doctors were sleeping. It was because he was abandoned at home and he was rescued too late. And you see here, this is an epidural hematoma, and here there is a measurement of the midline shift. This is, it should be the right frontal horn of the ventricle. It should be here. On the contrary, is totally pushed under the falx, and you see here more than 25 millimeters. More than 5 is really dangerous. And that lasted for a lot of time, because if you look here, there are signs of infection in the tissue. Usually the extradural hematoma is a sudden event, and it develops in hours or minutes. In this case, the patient stayed home more than one night and day. So let's concentrate on herniation. Herniation is something that happens, and we are used to think of herniation. It happens when ICP goes suddenly up, and then the brain is moved and distorted. But beware of one subtle important point. Patients can also herniate without a very huge increase in intracranial pressure. This is not a mystery. It depends on the location. If you have something like a contusion in the temporal lobe and the contusion expands, the deformation of the tissue is immediate. The gradient of pressure develops here. So this is a very old paper, but it is extremely important. If the patient has a symptom of herniation, even if ICP is not 40, don't be quiet, don't rely. It may happen that herniation in temporal contusion may develop at lower level of ICP. So again, we are supposed to be doctors, not just engineers looking at the monitors. And there are many components leading to this situation. And in traumatic brain injury, you see mass effect, edema, and vasodilation may all contribute. But in other pathologies, like subarachnoid hemorrhages, there are reasons for central herniation simply because of CSF, cerebrospinal fluid disturbances, like in acute hydrocephalus. So please be very careful about that. What happens when the patient herniates? The first issue is that there is a necrosis of the herniated tissue, and the second is that there is some nerve compression, which is very important because it's alerting the doctors on what happens. So back to anatomy. This is a view of the basis of the brain, and this is the tentorial hiatus I was talking about. And if you look at this foramen, you see that there is the third cranial nerve just passing through. It's very close to this opening. And that is the reason why, when there is compression, because the brain is pushing, is compressing, there is anisocoria and homolateral mydriasis. So I think that there are no limitations to the number of times that you can check the pupils. We can debate about opening the window with sedation to check for the motor response, but there are no reasons not to check the pupils very often. And this is a warning signal saying there is something extremely bad in the brain, with some exceptions. Medicine is not very easy, and there are stupid situations like a glass eye that may generate something that you can't understand and you can't interpret. Or what about a peripheral lesion? You have a facial injury, you have a peripheral lesion of the third, you will never be able to interpret the third signs as indicative of compression. So please be conscious about that. Then it may happen that there is a compression of the vessel. Again, back to anatomy. If you look there in red, there is the posterior cerebral artery. And one of the consequences of sudden herniation is compression of this vessel. And if you look here and you look carefully, there are branches of this posterior cerebral artery, and this is a very late sign of herniation, meaning that you understand the situation later on. Something wrong with the patient, you don't understand what happened, you do a CT the day after, and you discover this hypodensity in this territory. The meaning, there has been a compression of the posterior cerebral artery. Again, something we should prevent, not just look for. The perforating arteries, so smaller arteries going to the brainstem, can also be impacted. And this is, I think, a very important paper. In Richmond, in the USA, they were looking at patients with pupil disturbances, and they were using xenon CT, measuring the flow into the brainstem. The technology was very fascinating, but it doesn't work. So there is a caveat with this paper. The CT is very good for the brain, it's not very good to explore the brainstem. So I think that the paper should be taken with caution. But the idea was, if you look at the patients with anisocoria and a large pupil, the flow in the brainstem very often was critically low. So it may well be that the pupil was dilating not just because of compression, but because of ischemia into the brainstem. It may be. That is open to your interpretation. What is not open to interpretation is the Duré hemorrhage. This is a French name for a brilliant discoverer, and he described the occurrence of this kind of hemorrhages in the brainstem that have this very simple mechanical explanation. Think of the brainstem like a moving object. Unfortunately, the vessels that are providing flow and perfusion to the brainstem are not moving as well. They are stable, they are fixed. So when the brainstem moves, there are lacerations in these arteries, and what you see is this disaster. So you see something that you call is a brainstem mesencephalous pons hemorrhage. Okay, but why? And the reason is because of herniation. So again, is a late sign of something we shouldn't really see. If you want to take a picture, is this one. And what about the patients? Because we are trying to make sense of some signs that the patients are giving us. I think that, of course, there are some elementary and very strong indicators. The first is the consciousness. The patient with the epidural hematoma has a lucid interval, meaning he may arrive to the ER talking. And the definition many years ago was they talk and die. So they arrive talking and then they die. So that is because herniation develops afterward. And the second issue is the motor worsening. And this kind of posturing, that was the boy I talked about, is extension, this is pathological flexion, and this is nothing. If the motor response indicates a worsening, you should make sense of it. You should ask yourself why that happens. Simultaneously, if the brainstem is compressed and distorted, that causes a very strong response from the medullary system, so the adrenergic system, and that is really a storm. And that is the reason underlying the neurogenic pulmonary edema. So again, don't stop, don't block your attention to the edema. The issue is why all of a sudden the patient is behaving this way. And if you're reconstructing yourself what happens, the therapy is not to really improve the lung function, The therapy is to correct what is happening in the brain, causing this disaster. And what can we do? I think that, of course, we have to buy time. And to buy time, the first issue is, let's assume that the patient now has oxygen and has pressure. And there is pulmonary edema. Of course, it's a big issue. I am not saying that you should neglect it. Oxygenation is necessary. Do something. Increase the FiO2. Do something in order to restore oxygenation. The brain can't survive without oxygen and perfusion. But the second issue is to buy volume. We probably will have to remove some volume from the brain because herniation depends on pressure. And pressure in the brain is always a function of increased volume into the skull. For these reasons, I think that we should use mannitol, high doses. And there is a controversy here because all the papers proving that high doses of mannitol, half a liter, more than half a liter, in 5 minutes, very strongly, very quickly, came from one guy. It was Julio Cruz. He was previously in the USA, then he went back to Brazil. And unfortunately, investigations on some of these papers have cast a lot of doubts on the credibility of the data published. So I think that we have to be aware that there is discussion about how credible the papers are. But I think that the concept, despite the investigations, stays. And the concept is do something quickly and remove water. And this is more recent. There are no investigations on this paper. And if you use hypertonic saline, all in a sudden, you can reverse herniation. And I am sure that one of the chairmen likes this first line of intervention because we discussed with Pai Yang, and he likes this kind of approach. I like to combine that with another approach, which is hyperventilation, acute hypocapnia, which, to my sense, has been blamed in an unjustified way, but in this case can be life-saving. But I feel the necessity and the duty of remembering you that by using hypocapnia, we are causing temporary reduction of blood flow in the brain. That is the reason why many believe that hypocapnia is a blasphemy, is a big mistake. I am not among them. I think that when there is an acute ICP rise, you simply reduce the CO2, you increase the ventilation, the vasodilation comes to vasoconstriction, perhaps we are reducing flow in a very important way, but we are saving that life. And then we better do the diagnosis. And to do a CT today is quite easy. To do a blood gas and to measure sodium concentration should be a matter of seconds. So in these cases, we may take some information and we may identify the enemies. The first is an expanding hematoma, which requires surgery. There is no way to treat these patients in a good ICU. We have to use our best knowledge to identify the patients who need surgery. And surgery should be done quickly. Then, acute swelling, for instance, because of hyponatremia, or because of seizures, or because of hypoxia and hypercapnia. Many things that we can identify quite quickly and correct. So my suggestion, my advice is do these things of this list of things and simultaneously call the surgeon. Our policy is to have the surgeons looking at the CTs with us, not waiting for the neuroradiologist to look at the imaging, then give the interpretation, then dictate the results, and then informing surgeon. Surgeons should be with us, directly involved in treating these patients. So let me go to conclusion. This is a very old paper. It's San Francisco. It's many years ago. And the issue was, do we have time for doing a CT if the patient is herniating? So that was really a different era. 100 patients, and you see here, 56 patients were positive for hematoma. So the surgeons didn't wait for the CT. They saw the anisocoria, they opened up, and that is incredible. Arrival, surgery, 20 minutes. It's very American. I don't know about France, but I know in Milano, 20 minutes is the time just to start things. They completed everything. But I was thinking of this concept as a very old concept. But I was at a meeting in Seattle a few months ago, and in many centers, the concept of the golden hour has been modified to the golden 40 minutes. So they are still pushing time. They don't want to really to waste time. And I think that being European, we have to choose between these two possibilities. We may a little bit make fun of the Americans saying, you are Rambo. What is the evidence for 40 minutes rather than 60 minutes? What is the reason for not doing the CT and doing surgery in 20 minutes? Nowadays, a CT takes 2 minutes. So we can really make sense of things, but I think that the temptation for the philosophical Europeans could be to think, discuss, take a coffee, and rediscuss, and in the while the patient is gone. So I think that we better think of it with a kind of reasoning aggressivity, and don't forget that ICP kills. Thank you for your attention.